I'm excited for this presentation. What's Old is You, Next Generation Geriatric Guidelines, presented by the AAST, our grand rounds today on March 20th. We have a wonderful panelist here. We have Tanya, and I hope I don't mess up her name. Egodage, Elizabeth Gorman, and then Melissa Hornor. And again, I'm your moderator, Alicia Mangram. Can I have my next slide, please? So just a little background before we get into the sort of the weeds about this. You know, I got into G60 and geriatric trauma many years ago before people even knew there was such a thing. It's like way before people knew there was an electric car coming out. And it wasn't on purpose. It was totally by accident. It was just going down to the ER, being a normal, cocky trauma surgeon. And they said, "Hey, Dr. Mangram, can you see this patient? They have a tib-fib fracture." No, that's an isolated injury. Why on earth would I go see that tib-fib fracture? That has nothing to do with me. And it kind of went from there. They have a hip fracture. Why are you even calling me with that? I'm not the one to go see that isolated hip fracture. But over time, you know, I kind of started to see they were, you know, the ER doctors were really struggling with who's going to go see him then. The hospitalist said no, call trauma. Ortho said we'll operate, but we won't admit. In the hospital I worked at the time, Methodist in Dallas, they could cap out. So they're like, we're capped out. We've already admitted our 15 for tonight. We're capped out. So trauma's gonna have to admit. And then after that happened for a certain amount of time, something just came to me and said, you know what, why don't you just admit the patient? To them, they're in a trauma. They're not here with congestive heart failure. They're not here with their COPD. They're here for this fracture, even though it's isolated. Just admit them and we'll go from there. And then so I did. And if you look at this slide, the reason I had her put this slide up, and thank you, Caitlin, so much for helping me with all my slides today. You know, back in the 1900s, there were 3.1 million people over the age of 65. But if you look now where we are, I'm gonna go to 2040. We're talking 80 million people over the age of 65, and God forbid, 2060. You know, that's what 40 years from now. Hopefully, all of us on this grand rounds will still be alive. We'll make up the majority of the people. I mean, there'll be 94.7 million people over the age of 65. Now at the top, I kept it kind of light so you don't get too scared. But look at those people over the age of 85. 85 and older, this population is projected to be more than double, right? So we're going to go from 6.6 million, where we are 4 years ago, to 14.4 by 2040, age over 85. That to me is a tremendous, like incredible number. I literally equate this to my son wanting to take a OMO or UMO or what's it called? That car that there's nobody in there. Somebody help me.
The Waymo.
Waymo. All right. I guarantee you there are going to be a billion Waymos. People aren't going to have car notes. They're just going to be like, Waymo. You're just going to get on the phone and say, hey, Waymo, I need you. But at the same time, we're going to have all these people over the age of 85. Next slide, real quick. So this is just to point out, this is not our problem. This is not a United States problem. This is a world issue that's going to creep up on us, and we're not going to even know it happened. I mean, look at Brazil, look to the right, look at China, look at India, look at Japan, Russia, the UK, US. This is not a United States problem, and it is truly going to sneak up on us. It's going to be bigger than, I used to have a BlackBerry phone, and now everybody in the world has an iPhone. I mean, people that you would think can't afford a phone, they can get a used phone, a refurbished phone, whatever phone. And so our world of trauma has changed completely. We went from those young 20-year-old gunshot wounds to, you know, half of our list are people over 60. So I wanted to start there and give you a little bit of background, how I got involved. Um, I think we do better, period. I know a lot of people disagree with me and think that the medicine doctor that never took one course in compartment syndrome or one lesson in rib fractures and hemothorax and pneumothorax, that we should admit those patients to them because it's an isolated injury. I've always disagreed once I got over my cockiness of saying I'm not doing that. And I think we're going to have to continue to grow in that world. And with that, I would like to turn it over to our first speaker. Um, so let's go for it. Who's first? Caitlin, who's first?
Hello.
First up, we have Dr. Tanya Egodage.
Welcome.
All right.
Thank you.
Great. Thank you. Good afternoon. My name is Tanya Egodage. On that note, you've heard a little bit about the burden of disease. And today we'll be talking about some of the geriatric TQIP new guidelines. I'd like to thank the AAST, Dr. Mangram, and Dr. Boal Joseph for the opportunity to discuss today. I have no disclosures other than I am a member of the AAST Geriatrics Committee. And today we're going to talk a little bit about the literature behind and the changes to the TQIP best practices guidelines for geriatric trauma management, which were just published in November of last year. So we want to get everybody up to speed. Dr. Mangram was the chair of the expert committee, Dr. Joseph, obviously, an expert as well. So we'll get some insight today. Just to plug another effort by the AAST Geriatrics Committee, which was done in conjunction with the Injury Prevention Committee at the last annual meeting of the AAST, was a Stop the Falls event, which I encourage everyone to sort of read about and try to implement at their systems. It was an injury prevention event aimed at older adults, in which we educated participants about fall prevention, worked with the local UCI Trauma Center to offer local resources. It was a great event, well attended, and we'll be hosting it again at the upcoming annual meeting in Las Vegas. So I encourage all of you to join and learn about that injury prevention event as well. So why are we discussing this? When we talk about geriatric triage, what are the optimal components of triage? In a system that was created for younger patients in hemorrhagic shock, are the same tenets appropriate for older patients who suffer disparate pathologies? So is it age? Should we include age as our triage? Should we include mechanism, falls from stairs or even low energy, low level falls? Physiology, what are the physiologic parameters that should be included? Are they the same as younger patients? And what about histories and concomitant medications that patients take? Should these all be included in our triage patterns? So today we'll talk about the case of a sample case, an 89-year-old female who presents after a syncopal ground level fall. Her family calls EMS after they find her. She, on EMS arrival, has a GCS of 15. Her hemodynamics are as follows, and she is complaining of some right chest wall pain. They note a scalp laceration, and she's transferred to the ED. On the ED, the patient is evaluated. She has some, her airway's okay. She's tachypnic. She's got some crepitus over the right chest wall. Her hemodynamics are a little different. Her systolic blood pressure is 108 and her heart rate is 91. They also note her GCS is 15. They note a laceration to her scalp, some tenderness to her pelvis, and they get some additional history, including that she has atrial fibrillation and is on apixaban. So this is a sample image, some sample radiography where you can see the subacute emphysema and some pelvic fractures. So going forth, her labs are as follows. Her lactate is 4. She, on imaging, is demonstrated to have a subdural hematoma, multiple rib fractures, a hemoneumo, small hemoneumo, and some pelvic fractures. So really this is sort of serious for a patient who just had a ground level fall. And we discussed this with our AAST grand rounds a couple of years ago, in which we talked about whether geriatric trauma triage is important and what should we do. And this was done in 2022. And some of the takeaways were that it does matter, and pre-hospital triage sort of needs to account for geriatric patients and perhaps take age into account as well. As part of the reason that it does matter is that there does exist some bias in the care of this vulnerable older adult population. So this paper was published out of Norway and demonstrated that patients 65 and older were at risk for severe injuries. And they found in this series, retrospective review, that patients had increased mortality. They also had an increased time from alarm to hospital admissions, so a higher pre-hospital time. And they also had fewer air transports, fewer instances of being seen by a physician in the pre-hospital setting, which is part of the trauma system in Norway, and fewer instances of trauma team activation. So there is some bias that exists in this population. Furthermore, this was a retrospective analysis that was done of an EMS, the National EMS Information System, of older patients greater than 65 and older versus younger patients. And the primary outcome for this was scene time. And in a regression analysis, which controlled for demographics, pre-hospital interventions, and injury severity, we found that older patients sustained longer pre-hospital times with an odds ratio of 1.78, which increased sequentially as patients got older. So there is some bias, and what should we do about it, right? And part of that was the impetus for these new best practices guidelines, which were published in November of 2023. And I'll talk about what changes specifically to trauma team activation were recommended in this guideline. So first, let's talk about blood pressure triggers. In an NTDB review of over 2 years, which included over 1 million patients and compared patients over 65 to those who were between 16 and 65, this group found that they looked at the difference between a trigger of less than 90 millimeters of mercury per systolic versus a systolic trigger of less than 110. And they conducted a logistic regression analysis to determine whether they would have similar mortality or different mortalities. And this paper demonstrated that there was actually a higher sensitivity in the older cohort using a blood pressure cutoff of 110 millimeters of mercury, which increased the sensitivity of capturing injured patients from 5 to 13% with a higher area under the curve. Furthermore, this study by Heffernan and colleagues retrospectively evaluated patients who sustained blunt trauma, and they compared patients between the ages of 17 to 35 and those 65 and greater. And interestingly, they found that the patients, so an older cohort had sort of different physiologic triggers. So for the younger cohort, when they found a mortality increase at a heart rate of 130, they found that same mortality increase in older patients at a heart rate of 90. Whereas for systolic blood pressure, when they found an increase in mortality at 95 millimeters of mercury, they found that same increase in mortality at 110 for patients who were older. So as such, one of the new recommendations is to activate your trauma team when your systolic is less than 110 or your heart rate is above 90. So very important new physiologic criteria here. Now let's talk about shock index. This study performed by Bilal Joseph's group studied patients 65 and older in an NTDB review over 4 years and included 200,000 patients, looked at patients over the age of 65, and looked at parameters that would predict mortality. They found that on multivariate analysis that a shock index of greater than 1 was the strongest predictor of mortality with an odds ratio of 3.1. And they found that these patients were, again, had a higher mortality. They were also more likely to require blood transfusions and to have laparotomies and to have some additional complications. And they recommended that these patients should be transferred to a level 1 trauma center. So with that, the next part of our guidelines are that for patients geriatric patients with a shock index of greater than 1, you should activate your trauma team. Finally, let's look at what about on antithrombotic therapy or patients who have head injuries, which again, we'll talk about a little bit later on in our grand rounds. This study by Nishijima and colleagues looked prospectively at 5 EMS agencies transferring to over 11 hospitals in a 1-year period, and they looked at patients 55 and older with evidence of TBI, which included closed head injury, plus loss of consciousness, those with a GCS less than 15, and intracranial hemorrhage as documented on a CT. And they looked at long-term outcomes, specifically the GOSE score, the Glasgow Outcome Scale extended at 3 and 6 months to look at outcomes. They included 350 patients. Of course, the most common mechanism were low-level falls, and they found that for these patients, there was an adjusted odds ratio for anticoagulation use at 1.45 in all comers, with an odds ratio of 2.3 for patients who had traumatic intracranial hemorrhage, and that was for sort of worsened outcomes. So the final part of this trauma team activation recommendation is for patients with ground level falls on antithrombotic therapy, the trauma team should be activated. And for patients who sustain ground level falls, not on anticoagulants, but with a GCS less than 14 of signs of head trauma, you should activate your trauma team. So all in all, these are the new recommendations for geriatric trauma team activation criteria. Again, ground level falls for patients on antithrombotic agents, patients who have a systolic less than 110 or a heart rate above 90, those with a shock index greater than 1, and patients who sustain ground level falls who are not on anticoagulants with a GCS less than 14 and signs of head trauma. All of these should be included as your trauma team activation. And it's recommended now as a trauma center PI with, outcome measures of over 80%, and that this should be included as a standard audit filter. These are some of the references. And I thank you, and we'll open it up to any questions.
That was great, doctor. That really was. It was such a nice, thorough review of how we should change up our activation and who we should activate. I have a question, but I want to open it up and give other people a chance to ask any questions. Questions? I know it's hard to get off mute sometimes.
I don't see any questions in the chat box, but everyone is free to write them there as well.
Well, while we're waiting, if anybody does have questions, when we were working on these guidelines, trying to come up with things that we need to change as far as, trauma team activations, and they seem like little things like, instead of, systolic blood pressure, this, maybe instead of 90, it should be 110. And that may seem like, well, that's not really a big deal, 110. But we know it's a big deal. Instead of heart rate, let's make that heart rate less than 90. The problem is we as trauma centers, although trauma teams do a whole lot better, we take a long time to activate something so simple. And so my question would be, like, okay, the guidelines are out. Boom. Do you have something on your wall that says geriatric trauma activation? This, or whoever answers that phone and says, hey, we got this coming in. No, let's bring that here. That needs to be a trauma activation, because these are not hard things. We're talking simple numbers. And so my question really to everybody, but specifically to you, is how do we go about making those changes? Are we making those changes? Or are we going to be like normal surgeons and let 5 years go by before we actually believe the literature that we write? So I'd just love to hear your thoughts on that.
Yeah, Dr. Mangram, I think, the implementation side is always something that we talk about in everything we do. How do we implement these things? I think one of the first things is for us to have buy-in from our own, from our cohorts, from our trauma surgeons. I think this was a huge step for the publication of these best practices guidelines that, we can really tell everyone these are important. We should have trauma surgeon buy-in. And then again, I think communicating with the rest of your teammates, the nursing staff, the ancillary staff, getting buy-in from everyone and saying, hey, we're not just trying to increase work for everyone. These are important patient outcomes, depend on them. And I think that's part of it. But I think, the implementation side is always, not as straightforward as just publishing guidelines.
Yeah,
And
I don't know, Dr. Gorman, what do you think? I mean, the easy one is on anticoagulation. I think we all kind of sort of maybe, hopefully, I pray have that one, that we activate that. Just curious to hear other people's thoughts.
Yeah, we have a protocol at our hospital that I believe it's just verbatim actually from those guidelines that it's GCS 14 on anticoagulants, and that's been pretty effective. So I guess each hospital has to have their own guidelines, but I think if we all try to adhere to the ACS guidelines, that would be helpful.
I think so too.
I do see a few questions coming in, Dr. Mangram, as well, before we wrap up. Dr. Cools is asking, should we check a lactic acid on admission? So I think that might be something that we talk about a little bit later on. Is anybody talking about that?
Yeah, we'll save that one to the end. The
that
lactic
one to
acid.
the end. A GCS of less than 14, how do you account for known dementia in the elderly? That's a good question, Dr. Mangram. I'll trip that one to you.
Oh, they turf for them to me. Don't turf too many to me if you can help it. No, but that is a wonderful question because we do have patients that have delirium and the Alzheimer's and a lot of different things going on, and the majority are ground level falls, and we don't know what to do. And so right now, until we have more studies come out, the default should be less than 14. We admit them. In 6 hours in the morning, we could figure out, the kids get there and go, oh, mom's like that all the time. That's her baseline. Okay, then that's her baseline. But to assume or try to figure it out on arrival, we shouldn't do that. We're too early in trying to understand these patients right now. That's my answer.
There's one last question, and I'm so glad this question is asked because we were going to talk about it anyway. Dr. Thomas Chacon is asking, what about over triage rates, and have they been reviewed after trauma activation criteria have been instituted? And
let's save that one for that's an end question too, because those are the things that we really want to talk about. Perfect. So maybe we should move on to our next presenter because I want to keep everybody on time. I know it's late in the evening. I don't know, Dr. Gorman, are you next or Dr.
I am,
Gorman,
yeah. I'll share my screen.
Go for it.
All right, so thanks for the opportunity to present today. My name is Elizabeth Gorman. I'm a assistant professor of surgery at Cornell in New York. So today I was asked to present on two really important topics in geriatric trauma, anticoagulant reversal and palliative care. So I'm going to try to weave these together in one patient presentation. So this is a patient that came in a couple months ago, 89-year-old guy, presented as a level 1 trauma, pedestrian struck. History was significant for AFib on Xarelto, which he had taken that morning. He also had a stent that was placed in 2019. He had previous falls in the past and had a hip replacement before. So his vitals initially, he was hypotensive according to the last presentation. So his initial blood pressure was 100/75, GCS was 15. On exam, he had a foreshortened right leg that was externally rotated, and his labs are there. So in the Bay, we got a chest x-ray, which is grossly unremarkable, and we got a shot of his femur, which showed this distal femur fracture. And he was stable enough to go for pan scan, so we ended up getting a pan scan, which showed, as you can see there, a pretty bad spleen lac. They read it as the grade 3 with active extrav. So this is a list of his injuries. They were pretty extensive. So he had the spleen, he had bilateral rib fractures, sacral fracture, vertebral body fractures, and the distal femur fracture. So initially we called IR, thinking he could get embolized, but unfortunately he decompensated immediately after going to SICU. So activated MTP and brought him to the OR. In the OR, he ended up getting a splenectomy. He had a sigmoid colon injury. Unclear if that was iatrogenic or not, but that ended up being resected. He ended the case pretty unstable. His abdomen was left open and apthera was placed. So in total, he got 10 PRBC and 9 FFP and 2 of platelets. The topic I want to touch on here is that no anticoagulant reversal was given actually during the case, even though he had taken Xarelto that day. And you could definitely, make the case that this was life-threatening bleeding. Wasn't in the case, but I was told that the anesthesiologist gave pushback because of his cardiac history. But this is just to go through all these anticoagulants and their specific reversal agents. This comes directly from the TQIP guidelines. We're seeing this more and more often in our trauma bay, these elderly patients that are on, especially more recently, the DOACs, more so than the Coumadin these days. But so just going from the top here, so Coumadin, the specific test for this, as we know, is the INR, and that's really the most specific for vitamin K inhibitors, and for DOACs and NOACs, it's not quite as sensitive, but for Coumadin, it's accurate. So traditionally, people would give FFP to reverse Coumadin. However, in a geriatric patient population, you really need to think twice about giving that because it can give a ton of volume, sometimes 2-3 liters, and especially in elderly patients with, renal insufficiency, you don't want to necessarily do that. So I think for the most part, for life-threatening bleeding in these patients, most centers are going to consider giving Kcentra, which is 4-factor PCC. Just going ahead here, so our patient was on Xarelto. So we could check an anti-10A level. That's what's recommended here. The caveat for all of these tests is that in a trauma life-threatening bleeding situation, you're not going to have the time to wait for these results to come back necessarily. But the treatment for this would be, considering PCC, that's an antidote. There's also a specific antidote called Indexa, which is Indexinate alpha, which I'll talk about a little bit more on the next slide. And then for some of these other commonly seen anticoagulants, so, we often see people on Pradaxa. There's actually a specific reversal agent for that was recently approved called Praxbind. That's a monoclonal antibody to dabigatran. And then we often see geriatric patients on things like aspirin and Plavix, antiplatelet agents. Oftentimes you'll hear neurosurgeons ask for platelets and DDAVP, especially as someone with life-threatening intracranial hemorrhage. There's actually not a lot of great evidence that platelets actually are effective in this population, even if they're on antiplatelet agents, which I didn't realize. There's really no good evidence that it actually improves mortality. There's slightly better evidence for DDAVP. There's a couple studies that have shown that for mild TBI, giving DDAVP does slow the rate of hematoma expansion. So that could certainly be considered. So just to go through all of these in a little bit more detail now. So PCC, as I mentioned before, this is Kcentra. The dose of this is 25 to 50 units per kg. At our institution, we use 50 for life-threatening intracranial bleeding and 25 for everything that's not intracranial. There's also Indexinate alpha, which, as I mentioned, this was approved in 2018. And this is the specific antidote for anti-10 agents like Xarelto. I checked in doing research for this at our institution. We actually don't carry this, and I think that's probably because it's so expensive. So one dose of PCC is about $5,000. One dose of Indexa is about $22,000. So I'm curious, maybe we can talk at the end about the other panelists, what they have on board with their pharmacy, but we don't carry Indexa. Some other things that can be used, so TXA, these days is a little bit controversial. So I think most of us are familiar with the CRASH-2 trial, which showed that there is potentially a mortality benefit if it's given within 3 hours of the injury. There have been some more recent studies since that came out. There's a PATCH trial, which was published in New England Journal of Medicine in 2023, that showed really no difference in long-term functional outcomes, even if it was given in the pre-hospital setting. So at our institution, we don't use this routinely. Recombinant factor 7, this is more of a historical thing. I don't think many people use this now. It's been shown to have a pretty high rate of thrombotic complications, so it's no longer recommended. And then the last one I mentioned earlier, Praxbind, this is the antibody that binds directly to dabigatran. So going back to our patient, he ended up going back to the OR several times. Unfortunately, each time having more dead colon and small bowel that had to be resected. And I'm going to try to tie this into my next topic, which is palliative care. So this is the rest of his hospital course. He unfortunately didn't do well. He was still very unstable on post-op day 3. That's when we had the first discussion with the family about code status, and it was elected to make him DNR. Eventually stabilized, but then had to be reintubated for mucus plugs, and ended up not really recovering a great mental status, went into liver failure. We finally called a formal palliative care consult about 2 weeks in and had our first documented family meeting around that time, after which he went for a tracheostomy. Unfortunately, he, did worse, and about a month into his hospitalization, had another family meeting. He was made comfort care, and he expired shortly thereafter. So I put this stuff in red here just to show that, having early and frequent goals of care conversations is really important. We certainly could have done a better job here. So I'm going to use that to transition into my next topic, which is palliative care. So as I mentioned before, goals of care conversations, especially in these elderly trauma patients, is really important. They really need to happen as early as possible in the hospital course. And along those lines, if the patients have advanced care directives, it's really imperative that we try to identify those early on. And then family meetings should happen early and often. These are some guidelines from the TQIP guidelines that I think are pretty helpful. So, you want to make a meeting plan prior to the meeting. You want to try to do active listening, ask open-ended questions, and at the end of the meeting, try to summarize what was discussed. So I want to make a shameless plug for this website called vitaltalk.org, which is, I took a course from here last year, and it's very helpful. And a lot of the ideas that are in the new TQIP guidelines are also found on this website. So it's a course that's developed by palliative care doctors and people trained in palliative care, and basically gives you a framework with which to have these really difficult conversations. So something from that is, it's called the remap technique, which I'm going to just go through here quickly. So this is also in the new TQIP guidelines. So it's essentially a framework for how to have a goals of care conversation and kind of to structure your conversation, because they can be really difficult conversations. So what they recommend is to reframe the situation, expect emotions, map what's important, align with the patient and family, and then propose a value-based plan. So reframing the situation. So a lot of us do this already, but essentially you want to, ask the patients what they know about what's going on. That's usually the best way to start these conversations. And then after you kind of get a sense of what they know, then you want to give your headline of what you understand is going on. And you want to keep it brief, usually 2 to 3 lines, and keep it really simple, like using no medical jargon, using, 5th grade English. After that, it's really common to experience emotions from the patient's family. And so this is a great table from the newest TQIP guidelines, and also in Vital Talk. So these are NURSE statements, standing for naming, understanding, respecting, supporting, and exploring. So these are just some examples of how you can kind of anticipate these emotions and some phrases that you could potentially use. After that phase, you want to try to map what's important, and that's often the most difficult part of this, is to try to get a sense of what the patient's family would want, and or what the patient would want and what they wouldn't want in these hard situations. And then the last 2 steps, you want to summarize what you heard. So that's the align. So you want to basically show that you've been doing active listening and summarize what they've told you, so that everyone's on the same page. And then the last step is to propose a value-based plan. So I think it's really important as physicians that we actually, give a recommendation. So I think a lot of times we often give like a smorgasbord of options, DNR, DNI, and all these different things, and it can be really overwhelming for families. But if we kind of give recommendations, for example, if we see that care is medically futile, and, stating that and saying, maybe not doing chest compressions if it would not actually help the patient, that would be something that we would recommend, then, I think it's important to actually say that out loud. And, as long as that's aligning with what the patient's family has kind of been saying up to that point, I think it's pretty helpful. So that is all I have. I'll go on to questions. Thank you.
No, thank you, Dr. Gorman. That was actually great. Questions from the audience? Again, we'll try to save 10 minutes in the end, but I'm sure somebody might have some burning question that they might want to ask now. Please feel free. I can't see the questions. I can't see the participants. I don't even know if my hand's raised. I'm pretty close to computer illiterate. So whoever can see the questions, please feel free to say them. But I will say, I love that table, especially about palliative care. I'm not a big palliative care fan, but it's that emotion period that you never know. What is that? Is that a day? Is that 48 hours? Because it's not an hour, that's for sure, you know. So that emotion phase is really the phase that to me is, they're like, well, Dr. Mangram, they're still very upset. Well, give them time. But how much time? Am I going to give you 4 or 5 days to figure out what emotional state you're in, or we're going to make that shorter? But I still love the table. I love the way it's structured because that's exactly what happens. So maybe your comments about the emotion phase of that in palliative care.
Yeah, I mean, I think that's absolutely true. So, you can have no emotional response sometimes. You can see that. You can have an emotional response that goes on for a long time, and effectively that's the end of the meeting. So it's just going to be different for every patient and every family. But I think, what the guidelines are trying to recommend is that these are dynamic meetings that happen regularly so that, oftentimes we'll end a family meeting and then, convene the next day or the next week, and things change, and families need time to process things.
I'm sure Dr. Joseph is taking notes on his next paper because, we get dinged a lot and, oh, you got to work on your length of stay. Your length of stay is too high. Your length of stay is this. And maybe we pull out, okay, let's separate our length of stay from those where we had to call palliative care and how long that took for the family to decide versus our true length of stay. So definitely something to look at. Any other questions raised, or are we saving them to the end? Should we move on to our next speaker? Caitlin, you're the boss.
All right, I'm up next. I'll share my screen.
All right, Dr. Hornor, welcome and thank you.
All right, let me just switch that. All right, so I'm Melissa Hornor. I'm a trauma surgeon at Loyola University Medical Center in Chicago. And I'm going to speak today about managing frailty in geriatric trauma patients, and then just a short topic on the syncopal workup. So 3 objectives for my talk: to learn how to assess geriatric trauma patients for frailty, understand interdisciplinary frailty pathway care and how to implement that at your institution, and then lastly, just how to work up syncope in trauma patients in a logical manner in a way that you can actually figure out what's going wrong with the patient. So frailty. Frailty is defined as a state of decreased physiologic reserve that results in an increased vulnerability to stressors like surgery and trauma. It's age-related. Frailty assessment has emerged as the most reliable form of measuring an older adult's likelihood for adverse postoperative or post-trauma outcomes. And frail patients have been found to be more than twice as likely to experience in-hospital complications like unplanned ICU admission, VAPS, delirium, and then also increased discharge to skilled nursing facility. So why does frailty matter? Well, once frailty is identified, interdisciplinary frailty care pathways can be used to target vulnerabilities and prevent complications related to frailty. So I'll talk about frailty and frailty pathways through a tale of 2 geriatric trauma patients that you may recognize from a sitcom in the early 90s. So One of our patients is an 81-year-old female who presents after fall from standing. She was found to have 3 rib fractures on the right side with a small hemopneumothorax that's treated with a pigtail chest tube. She does well. Our next patient is an 81-year-old female who also presents after fall from standing. She was found to have a 0.5 centimeter subdural hemorrhage and a hip fracture. She's not on anticoagulation. Her GC is a 15, no focal neurologic deficits, and she gets her hip fracture repaired uneventfully. So how will you be able to predict how well these 2 geriatric patients that we can agree are similarly injured will do during their hospitalization? Well, I would argue that assessing their frailty score will allow you to tailor your inpatient care to the patient's unique needs. So how do you measure frailty in trauma patients? One way is through the trauma-specific frailty index, and this is a table taken directly from the geriatric trauma guidelines we're discussing. So this is made up of 15 variables from 5 different domains. I have boxed here an example score for this patient who, let's say, had a history of breast cancer, so scored 1 for cancer history, had mild dementia, needed help with managing money and doing housework, but otherwise was functionally independent, had no deficits for health attitude, but did deny sexual activity and had a albumin less than 3. So if you add all this up, you get 5.25, and how this score works is you would then divide it by 15, and a frail patient score is greater than 0.25, non-frail is less than 0.25. And then I'll just mention another option for a frailty screen, and this is also validated in the literature, first published by Morley et al. And this is a frail screen using frail as an acronym, where you essentially ask the 5 different questions to the patient. Are they fatigued? Can they climb a flight of stairs? Are they able to walk a block? Do they have 5 or more comorbid illnesses? And then have they lost 5% or more of their weight in the last 6 months? And if they score above 3, they're frail, 1 to 2 considered pre-frail, and 0 robust. So this is a bit more simplified version that we actually use at my center and have had some success with measuring frailty in our geriatric trauma patients. So let's go back to our 2 patients, and we found out that they had the exact same trauma-specific frailty index. They were both classified as frail. They're both getting their trauma-related care is standard of care. Like I said, our first patient had a pigtail chest tube for the hemothorax, is doing really well from a respiratory and pain standpoint. And then our other patient with the hip fracture got the ORIF of her hip and neurologic monitoring for the subdural and is completely stable. But what about the remainder of care in the hospital, which can be a dangerous place for geriatric patients? So this is where frailty pathway care comes in, and I argue can help avoid micro harms to patients like this that can spiral into big complications. So here's an example of a frailty care pathway. So this care pathway, there's also an example in the geriatric trauma guidelines, but this frailty care pathway looks at frailty from 4 different domains. From the delirium prevention domain, nurses will measure delirium in their patients using the confusion assessment method. Non-pharmacologic management of delirium is employed using frequent reorientation, making sure that geriatric patients have their blinds open during the day to regulate the sleep-wake cycle, and encourage visitors to come see them so they're more oriented to where they are and what happened. Minimize opiate and benzo use and avoid polypharmacy, and pharmacists can help with this component. To avoid aspiration, nurses can perform a bedside speech and swallow screen. Again, to regulate sleep-wake cycle, these type of pathways will avoid overnight vitals and labs when that's able to be performed safely. Importantly, make sure your patient has their hearing and visual aids. I've often heard patients are hesitant to bring in their hearing aids, for example, because they're afraid they might lose them in the hospital. Yes, that's a risk, but it's definitely worth it in order to prevent delirium and complications from happening. Early nutrition and a bowel regimen is also a part of delirium prevention. For the mobility standpoint, this just get your physical therapy colleagues on board to get these patients ambulating early and eating their meals out of bed, importantly. From a goals of care standpoint, important to identify a healthcare proxy, even if the patient is doing fine, that something might happen where they won't be able to speak for themselves. So it's important to have someone identified, establish their code status, and then have a family meeting, especially if their stay exceeds 5 days. And the social work and palliative care, if needed, can help with this component. And then finally, injury prevention is involved in this pathway, where fall prevention education can be provided by physical therapy or social work. So there is good evidence for frailty care pathways. This study was a pre and post intervention study, found that post a frailty care pathway intervention after risk adjustment, patients were found to have a lower delirium and 30-day readmission rate. So you might have saw where this is going, but in terms of our 2 frail patients, one received frailty pathway care. So she received care structured around her sleep schedule and frequent reorientation. She walked 3 times a day and ate her meals out of bed in her chair. She was given her glasses and hearing aids, and polypharmacy and deliriogenic medicines were avoided. She went home 2 days later after she got her chest tube removed. Our other patient, unfortunately, didn't go to a hospital that had frailty pathway care. Her labs were drawn at 4 a.m. Then she complained that she couldn't sleep, so she was given 1 milligram of IV lorazepam. After that, she developed hyperactive delirium. She fell while going to the bathroom and broke her other hip. And then, since she was bedbound, developed a pressure ulcer after she remained in bed due to being labeled a high fall risk. I know that this case represents somewhat of an over-exaggeration, but I'm sure we all have examples in our minds of geriatric trauma patients that were initially doing fine, and as a result of small micro harms that are just come with being in the hospital, like dysregulated sleep cycle or a medicine that induces delirium, that those kind of things can spiral into a situation where the patient experienced multiple complications. So now I'm going to shift gears and just talk about syncope. Syncopal workup to me has always been a frustrating thing, where we get all these tests that none of them are positive, and we never really find out why they syncopized in the first place. And I think the geriatric trauma guidelines have a really logical, good way to work up syncope. So we'll talk about a patient here with a very deep, soothing voice you may recognize, who is an 85-year-old male, presents with a syncopal fall from standing. So he describes stubbing his toe, then he got sweaty and lightheaded, and then he woke up on the ground, having landed on the left side of his body and head. He has a 3-centimeter scalp laceration. His vital signs are normal in the ED, normal EKG, and normal cardiac exam on auscultation. Your primary and secondary and his full PAN scan are essentially normal. He just has that 3-centimeter scalp plaque that's repaired. And he's GCS 15, feeling better, and asks, "Doc, can I go home now?" So I'm going to argue and hopefully convince you using this recommended syncopal workup that this patient probably could go home, since he has reassuring vital signs, reassuring EKG, and cardiac exam. So a little bit about syncope and the etiology. The cause of syncope does remain unknown up to 37% of the time. But when we do discover, it's often a vasovagal response, which is what our patient stem was trying to indicate when he stubbed his toe and felt sweaty and lightheaded. Orthostatic hypotension is frequently a cause in our patients with older patients with stiff arteries, and maybe on too many blood pressure meds or dehydrated. Intoxication. And then these ones with asterisks are ones that are more serious conditions that do deserve an inpatient workup, like a cardiac arrhythmia that might have caused it. A non-arrhythmic cardiac condition like aortic stenosis, seizures, stroke, hypoglycemia, and anemia. So the suggested syncopal evaluation and the guidelines are: 1, just get a good history and assess for triggers. If you can really find a trigger that sounds benign, then that can reassure you that it was a vasovagal response and not something more dangerous. obtain orthostatic vital signs to rule that out as cause, get an EKG, and then dust off your stethoscope and actually listen to their heart to try to identify structural heart disease that would be indicated by like a new systolic murmur. Add an echo to their workup if there are any abnormalities on EKG or that's recommended in any patient undergoing surgery. You can add cardiac telemetry if the expected etiology is a cardiac arrhythmia, but even then the diagnostic yield is low. And then finally, do a full neurologic exam to identify focal deficits. In the absence of deficits in a normal neurologic exam, no further neurologic workup is indicated. I'm looking at you, carotid duplex. And lastly, to finish my discussion on syncope, this is a list of low risk and high risk factors in the syncopal patient. Low risk is was described by the patient STEM. So a patient that has a prodrome with sweating and lightheadedness after they had a painful stimuli. If it happens after prolonged standing or exercise, if it's triggered by a vagal maneuver, and they also have a normal physical exam and EKG to reassure you. High risk type conditions that you could get from the history is if it's associated, the syncope was associated with chest pain, palpitations, shortness of breath, abdominal pain or headache. If it happens during exertion, that should be a red flag that it could be coronary artery disease. If it just happened all of a sudden, there were no warning symptoms, that's a high risk condition, possibly. Family history of sudden cardiac death, if they have a history of coronary artery disease or structural cardiac disease, abnormal vitals, a new systolic murmur, other red flags like they have a history of pulmonary hypertension or you see an ICD on their chest x-ray, and then abnormal labs like hemoglobin less than 9 or BNP greater than 300. And this list is all in the geriatric trauma management guidelines, and this QR code will take you right there. So I just wanted to reiterate my 3 take-home messages, which hopefully I've convinced you of. That frailty assessment is important in trauma patients, and you can screen your geriatric trauma patients for frailty. Frailty pathway care has the potential to save lives, and you can do this too. The components are usually in place at each hospital, and you just have to get your interdisciplinary care team ready, and it can possibly be done. Then thirdly, syncopal workups can make logical sense and can yield important diagnostic and therapeutic results. Thank you, and I wanted to assure you that no Betty Whites were harmed in the making of this presentation. And here's the QR code to the geriatric trauma guidelines.
Very good, very good. Thank you, Dr. Holman. You picked 3 of my favorite actors. Actors. That was really, really good. Really good. Again, I have a million questions because I only have 2 loves right now in the world of medicine, and one is geriatrics and the other is robotics. So I get the best of both worlds. So I want to open it up and see if we have some questions. Questions from the audience. I see we have like 41 people participating. I know you guys have questions. And Caitlin, help out.
Yep. So right now I am seeing just those 3 questions from earlier. So I know that you all said that you were going to come back to those. So would you like to start with Dr. Cools?
And which one was that?
Her question was, should we check a lactic acid on admission?
Yeah. If anybody wants to tackle it, feel free. I'll give my thoughts on that. You know, when I think of lactic acid, I think of lactic acidosis. I'm a big bicarb fan for whatever reason. Just bicarb to me gives me a whole lot of information. I get it back super quick. I think lactic is about the same to make sure that these patients, especially the ground level falls or those patients that are found down, it can definitely give you good information. We check lactic acid. And the thing I love about Epic is I love to watch the curve. You can get a curve on everything, going up, going down, however. But the answer, should we? I think my answer would be yes, but it's not based on 100% that's the answer, because I remember one of the first papers that I had to review was more on pH, looking at pH in patients with a pH of less than 7.2, and not so much that the lactic acid was going to increase their risk of mortality. It was more of a pH. So my answer is vague. If it can come with your panel, yes. But I think having an ABG, looking at that bicarb to me tells me just so much. It's like my minute ventilation when I'm looking at a ventilator. I don't know. I'm gonna put you all on the spot. Dr. Gorman, Dr. Hornor, what do you think?
I think lactate can be helpful, especially to trend it. And you can expect it to be elevated sometimes and not necessarily, suspect ischemia, but just kind of like stress initially. But I think it's helpful to trend.
Dr. Gorman?
Yeah, we get it routinely. We'll get a venous gas when patients come in. I think it's just helpful as a marker that they're sick. I don't know if it does much more than that. I think the pH for me is more actionable because you can actually do something about that. But yeah, we get it routinely.
All right, very good. The next question, I believe, was about the under triage. Was that correct? So I've had this question. I just came from a conference, and we were talking about, old people, ground level falls, and we don't want to over triage, but we definitely don't want to under triage. And we're in way more trouble if we under triage. To me, if they meet the criteria, and we put a lot of thought into this guideline. This wasn't a 2-month guideline or a 3-month guideline. This is about a 1.5 year, almost 2-year guidelines. We checked, we rechecked, and you're better off to just over triage a little bit, but you don't have to over triage for a very long time. And by that, I mean, you have your highest level, your red, maybe your next level is yellow, maybe your next level is green, maybe it's 1, 2, 3 activations, but you're better off to just go ahead and over triage, and in 3 hours, maybe they go to observation, or in an hour, maybe they go home. But the worst is the opposite, because, my mom fell, she's 80 years old, but she's fine. Her frailty score is good. She takes care of herself. She drives, but they forgot to tell you that she takes like aspirin 3 times a day. They just, oops, forgot about that one. And then she bleeds. And so the over under triage, as we learn and grow more about taking care of our elderly, we should be very okay to over triage, but fix it soon. Okay, fix it. I mean, they live their whole freaking life and paid for Medicare, Medicaid, whatever, United Healthcare, Blue Cross, Blue Shield. I am not worried about, over and under triage. I want to make sure I'm not missing anything. So those are my thoughts. Putting y'all back on the spot again.
I think there's probably room to investigate that a little bit further, given all of the new guidelines. But some of the literature that's been there has shown that the rates of over triage outweigh the rates of under triage, and so we're actually capturing more sick patients than we are. So and most of them show also that we're within the acceptable ranges for the ACS-COT, which is between 25 to 50% over triage. So I think, as Dr. Mangram is saying, more to come in the literature, but so far, at least in isolation with each of those parameters, it hasn't changed the over triage rate too much.
And there's a really good paper. It's an older paper. It's titled like Old and Under Triage, a lethal combination, something like that. Because that's what happens if we miss it. That's a lethal combination if we miss an injury. And so the over triage, I think it's a 2012. It's probably, I know it's cited in the guidelines somewhere. But yeah, so those are kind of my thoughts with the over and under triage.
I think there are a few more questions. There's one, what's the best way to implement all of the best practices guidelines, given there's so many new recommendations? Are people admitting isolated hip fractures? Can we comment on admission triage to the regular med surg floor versus the intermediate care and post-op labs and frequency? So I don't know if we have time for all of those.
That sounds good. Give it a whirl. Go for it. Yes, you answer it.
So the best way, I think there was a paper that Vanessa Ho wrote about like sort of implementing some of these guidelines, and it has a three-pronged approach, including education, consultation, and something else. So I think, you know, there is sort of an evidence-based way to implement some of these things. And again, you know, there are quite a few, but I think we all see the morbidity and the mortality associated with these patients. So it's on us to
Right.
sort of champion these educational initiatives and make them happen.
Dr. Gorman?
Yeah, I mean, I think like going back to Melissa's talk about frailty, I think that's a really great idea to have a frailty pathway. In theory, I think the reality is you have to pull all these different services together, and it really does have to be a multidisciplinary approach, and you need buy-in from a bunch of different people, and maybe an automated Epic guideline that could guide you through those order sets. So yeah, I think it's a challenge. I don't know what the right answer is. I don't know if Dr. Hornor, maybe do you have somewhat like a pathway, for example, at your hospital for frailty that you use?
We have been working on one. Nursing really is key. I think the delirium prevention stuff is really centered around nursing and the regulating the sleep-wake cycle. Pharmacy is pretty easy to get involved too, to like help you with med-rec and avoiding polypharmacy. And then PT and OT are always, they're not really changing what they do much by making sure they get early ambulation. I think it's also important to make sure the residents have their like weight bearing restrictions all ordered and so they can work with them early on. So, but yeah, I think it's just getting the stakeholders together and then telling them how important it is, and we've had some success here.
One of the things that you said that I thought was just really key when it comes to frailty, and I think frailty is big. One of my nurse practitioners who actually helped work on the guidelines, she's really big with frailty, and I've been looking at frailty for about 11 years. I wrote a paper using the VES, Vulnerable Elder Survey, looking at frailty, because I think frailty is more of a key than we think of. In other words, if you came in and you fell down Camelback Mountain, on mile 2 and broke something, you're going home tomorrow. Okay, you're out of here. Versus staying here or us keeping them there because we don't know, they're not frail. They're just hurt. They're hurt just like a kid is hurt. As long as they get their pain medicine and have everything they need and drink their water, they can go. And if we start to look at frailty it's almost as part of our algorithms. One of the algorithms we talked about, we have A, B, C, D, E, and at the meeting that I just came from, they want to have X, C, A, B, E. And the X is for exsanguination. Like, I don't care about the airway no more. Let's stop the exsanguination. And they made a really good point. Why doesn't everybody have a, stop the bleed tourniquet in your car? Why would we not have that? And why would we not have a patient that comes in and work on exsanguination? And for me, why would we not know how frail this patient is? Because every 88-year-old is not 88 years old. And so, sweetheart, if you were walking and you did your mile walk every day, I'm sorry you broke your leg, but you're going to go to rehab and you're leaving the hospital, because we know what happens with every day that they stay. We have a site visit coming up, and my young trauma medical program, whatever, we're like, they always pick the ones with 16 days and 18 days stay and 15 days stays. What about the ones with 1 day and 2 day? Because there's nothing wrong with them. They went home. They want to see, what are you doing to cause them to have this long hospital and to stay. That's what they want to see. So I hope that helped answer some of the questions.
And the longer they're in the hospital, the more likely they are to just, have those problems like the disrupted sleep-wake cycle that causes delirium, and then they get confused and fall. And
Yeah. No, I thought that was perfect in that example. So that's exactly what happens. Okay, now this one goes home. This one, oh, I can't sleep. Somebody gives them some lorazepam. Now tomorrow they're confused. Now they're this. You should have just sent them out. If we follow these things, and I think we will, I think we're headed in the right direction. I'd like to hear from our leader, if he's still on. Dr. Joseph, are you still there?
I guess got permission to speak, so sorry about I was on I was like everyone else, I was putting questions in, but your question again, Dr. Mangram, was just about frailty or in general, like
Just in general, just kind of wanted to hear from you.
yeah, I think
We
that
can
look, I think that
we consider you our geriatric leader, so we just
know,
wanted to hear from
we're following
you.
your footsteps, but I would just say that I always my favorite line that I've kind of touted is trauma systems were built for bleeding patients. And everything we did for years was to how to be better to deal with young bleeding patients. And now trauma centers are being run, I don't care where you are in the country, with, older adults who suffer a trauma, like you said, whether it be hiking or biking or driving or a ground level fall. And I think the future is, first, we've identified, and that's what frailty does. It helps you identify, because you can't do everything for everybody. And now we're implementing best practices. And I think that's what the ACS COT best practices does. We're learning how to integrate those things into our day practice and speak the language that we need to speak. And, Alicia and everyone on this call and this session, which, first of all, congratulations, was phenomenal. And then the third phase is going to be change the infrastructure of what a trauma bay will look like in 5 or 10 years from now, because that's where we're headed. And I think that we cannot continue to believe that what we designed 30 years ago during the crack wars and gunshot wounds is really what in high volume, blunt centers, although we're going to be getting those patients. Now put the word elderly in front of them, it changes everything. So I see this is such an exciting field with so much more work to be done. We don't know half of what we do. We make it up as we go, and then we try to write about it to create it. And I think, it's funny. I saw, Melissa, you mentioned the frail score, and TSFI, it took us 12 years to just get frailty to be recognized, right? Like it didn't just happen. And Alicia, how many things have the G60, how long have you been chasing that and putting that in front of the world? And still to this day, we're like, what? And I don't mean that in a bad way, but this is our generation will be to disseminate and accelerate the care of older adults into infrastructure and trauma systems that make a difference. So.
Yeah, I really appreciate that. I love those comments. I just want to open it up. If anybody has something to say, now's the time to say it. Well, I really can't thank our presenters enough. Deborah, you have something to say? Go
Yes,
for it.
I have to wait to have permission to speak. Um, y- yeah, I guess number one, great talk. Really great evidence-based guidelines. And I think we'll all have to take a look at whatever our protocols are and see where we can incorporate them. But one of my questions has really to do with follow-up. And I kind of put a question in the chat. Um, we're finding that some patients, like initially they'll look fine, we'll check labs for a day or two, they'll look fine. And then all of a sudden they like crump, if you will. And I'm just wondering, like for follow-up, sometimes we can't get people out to rehab quite that quickly, right? And we would kind of fear something bad happening to them in rehab. So I'm just wondering how everybody follows those patients. And I guess I'm speaking mostly to like hip fractures and femur fractures and those types of injuries.
I think there's an idea of sort of ongoing triage, which we've discussed within our geriatrics committee as well, which doesn't stop when the patient sort of, and Dr. Bilal Joseph has talked about this as well, but it doesn't stop when the patient sort of comes to the hospital. There's sort of an ongoing assessment and re-triage when the patients get admitted, and how that's done, I think, is still up for us to determine. But that idea of triage sort of doesn't stop when the patients get admitted. That is sort of ongoing with the changes in level of care and things like that. So
We've implemented if our patients screen positive for frailty in the trauma bay, admitting the SICU to start. And we do end up having some patients that they're in the SICU and we don't really do much for them in the SICU. There's definitely like an over triage to that. But we've found that our unplanned ICU admissions have gone down with that. So that's a consideration, to use like frailty as a screening tool for where you put them in the hospital.
The other thing I would say is, what we did is, our clinics are already full enough. And I think that we have integrated, we went to our medicine colleagues, our geriatricians, and said, listen, for the frail or over the age of 80, like, because age matters. I mean, it's not all frailty. Age does matter a little bit too. But if you're over 80 or over the age of 65 to 80 and you're frail, we asked, could you have they're still going to come to trauma clinic, right? 7, 10, 14 days, but could they come to a frailty clinic within 48, 72 hours? And it's amazing how much that's made a difference with just ability to just check on them, how, their medications, their follow-ups. And so there's this idea of an earlier follow-up through medicine, which we put together with them, and then the follow-up still happens at trauma at some point.
How about when they're in an inpatient? We have a certain segment of our patients that they seem to do okay. We check on them post-op day 1, post-op day 2, and then I don't know if it's when we restart aspirin or Lovenox. We haven't drilled down to it quite then, but then they sort of they crump at that point. And another question is, what is your transfusion trigger in these patients?
Now you're asking hard questions.
It's just, I
Well,
think
that's why we come to you.
the longer they're in the hospital, the more vulnerable they are to just these, the dangers of the hospital and getting confused, getting delirious, getting a medicine you shouldn't have gotten. So I think that's why you end up seeing it 3 days later.
Yeah, absolutely. I I want to be sensitive of everybody's time. I think this is a great beginning of a discussion. I'm looking forward to the meeting in Vegas. Hopefully I can make it. I am a firm believer that 60 is the new 40 and 70 is the new 50 and 80 is the new 60. I can't tell you how many 70-year-olds come to the hospital and say, oh, I fell on doing my 5K run, or, you know, I was riding my bicycle, or I was playing, get ready, pickleball. There's another study, Dr. Joseph, pickleball or tennis. But these are the things we see. So again, I really want to thank everybody. I want to end with it's not funny, but it's real. That last little video, Caitlin, if you could put that on. And then again, we'll close from here. Can you put that on for me, Caitlin? Okay, that's good. And there's more to that. You can watch stuff like that, but these are the things that happen every day. And I know you guys see it, we see it. Like I said, there's more to it. Again, I truly want to thank everybody. I thank you, Dr. Joseph, for inviting me and asking me to moderate the session. If anybody has questions, wants to talk about the guidelines or anything at all, feel free to reach me. It's easy. Just call Honor Health, and my phone number's on every call schedule, my cell phone. So once again, thank you all, and everybody have a great day.